So I think, Brad, go ahead and get started.
Okay. Thanks, LaGreer and SERPA for inviting me to run through attribution methodology. So I have a very short PowerPoint that I'll go through, and then maybe we could have a discussion. I'm sure there'll probably be some questions. As I'm going through the slides, if anybody has any questions, feel free to chime in. Well, I guess people are on mute though, so maybe we'll do a Q&A afterwards. So as I'm sure most of you know, we partner with a vendor, 3M Analytics, that helps us with our monthly attribution process. So what I'll do is I'll walk through their monthly process and I'll tell you a little bit about how this works, what the process looks like. So first, some really basic kind of building blocks. So what is attribution? So it's assigning a member to a provider, specifically to a primary care provider. And the purpose behind that is so that we can then have tie that member back to that provider, that patient back to that provider. And then that provider is then responsible for their care, right? So the cost and the quality of that member's care or that patient's care, holistically. So not only what happens within the clinic, within the primary care clinic, but for the total cost of care and the bigger picture for that member. So all medical services received. So how is our attribution performed? It's based on historical claims utilization, which is typically a 12-month, but sometimes a 24-month look back, and I'll get into the details with that in the next couple of slides. But just know that attribution is performed every month, so it's refreshed, so to speak, when we push the dashboards out every month, which this month will hopefully be happening later this week or early next week for the August refresh. So there's three basic pieces of information that we consider when completing attribution every month. So we are looking at specific types of providers in terms of providers that are eligible for attribution. So you can see those on the far left. These would be physician types that we would consider primary care physicians for our value-based programs. It's also important not only to look at the provider specialty, but to also look at where the services are occurring. So you can see the far right column as bill type descriptions. So we're looking at office, FQHC, independent clinic, things of that nature. So that we're only considering attribution if all three metrics are met. So the specialty, the bill type description, as well as the middle column, which is we're looking at E&M codes, right? So we're specifically looking at CPT codes between 99201 and 99499. So in order for a visit with a physician to be counted towards the attribution methodology, it needs to hit on all three criteria. So it needs to be a doctor that has a specialty description within our credentialing system of one of those in the left column. They need to provide one of those CPT codes within that range, and the service needs to be provided at one of the types of locations in the right-hand column. If one of these criteria is not met for a specific visit, that visit will not count in the attribution logic. So let's take a couple examples. Let's say there's a family practice doc providing a E&M code, but they're doing it within let's just say an urgent care clinic. So that visit would not be eligible for attribution because of where the services are being provided, because we wouldn't consider an urgent care clinic a primary care setting. Or let's say it's an internal medicine doc who's providing services. He's moonlighting in, let's say, an emergency room somewhere. Those services would not be considered under our attribution logic because it's not meeting all three sets of criteria in terms of the specialty, the CPT code, and where the services are being provided. I know that in the past we've had some questions from ACOs related to, we saw this member X amount of times within the last 6 months, but this member still isn't attributed to us. So we've kind of taken some looks into the data, and what we're finding sometimes is if somebody has a chronic illness to where they need lab drawn very frequently, that individual's coming in, they're seeing the right provider type in the right place, so the bill type's fine, but there's no E&M code on the claims. So they're submitting claims for just for the lab draw only. So again, when thinking about this from a holistic perspective, all three criteria need to be met for attribution, or for that visit to count towards the attribution methodology. So let's talk a little bit then about the steps in the attribution process. So we have this little diagram here going from left to right. It's important to note that we go through this process twice. So once at a provider group level, and then once at a PCP specific or individual provider level, and I'll kind of explain what that means as we walk through this. So the first piece is very simple. So you pick the provider group with the most E&M services within the past 12 months. I'm sorry, let's go back to the previous slide. There was one thing that I forgot to mention here in this data period. I had briefly mentioned that typically it's a 12-month look back, and sometimes it's a 24-month look back. So what we do to maximize attribution is we will look back an initial 12-month period to see if there are visits that meet criteria for attribution. So the right specialty using an E&M CPT code provided in the correct place of service. If there's just one of those visits within the last 12-month period, that patient would have met criteria for attribution. However, we know that some people don't go to the doctor's office very often, so maybe they don't have a chronic illness, they just go in for an annual wellness visit, but let's say they haven't been in the office for 14 months. So if we didn't have that extra 12-month look back period, that member would fall off of attribution. So what we've done is we take that initial 12 months look back. If for members that meet eligibility criteria for attribution in that initial 12 months, we will go ahead and attribute. And then what we will do is we'll take an additional 12-month look back for a total of 24-month look back for individuals who are not attributed within that first 12 months. So again, that gives us an opportunity to attribute members or patients to ACOs where that weren't attributable within that first month based on historical claims utilization, or excuse me, within that first year, the first 12-month look back. So back to the slide. So what we do is we pick the provider group with the most E&M services within the past 12 months. We attribute to a physician group before we attribute to an individual physician within a group. And I'll run through an example of that on the next slide. So look at the provider group with the most E&M services within the past 12 months. So it's important to note that with this step and this step only, we're able to attribute for members who have met criteria, meaning somebody who's had an E&M code with those types of providers within the last 12 months, we're able to attribute 99% of our attributable population just using that step. So we have these other 3 tiebreaker steps. So know that when we get to these tiebreakers, we're talking about very few individuals. This is less than 1% of our overall attributed population. So again, we'll pick the provider group with the most E&M services within the past 12 months. So if there's been a tie, so like say there are 2 clinics that both have had 4 E&M code visits over the last 12 months with the same member, then what they will do for a tiebreaker is they'll look at the most non-E&M services provided by each clinic. And at that point in time, if there's one that has had 2 non-E&M visits and one that's had 1, they will attribute that individual patient to the clinic that has 2 non-E&M visits over that 12-month reporting period. If there's still a tie at that point, so let's say each clinic had 1 non-E&M visit, then they'll go to the provider group with the most total visits within that 12-month period. And again, if for some reason there's a tie at that point in time, this person has seen, each clinic for a total of 4 visits, then they will go on to the next tiebreaker. And so the final tiebreaker is they'll pick the provider group with the most recent visit. So just know that when we're getting into steps 2, 3, and 4 here, we're really getting onto the very last part of the tail of that bell curve, right? We're thinking about just very few individuals. The vast majority get attributed within that very first step. So then what we do is we go through that process and we've attributed to a provider group then, right? We've identified clinic ABC has attribution for this member because they have the most E&M services within the past 12 months. So then what we will do is we will look within that clinic to determine attribution to a specific primary care provider within that clinic. So within that clinic, this member may have seen 4 different docs within that 12 months. Maybe he saw Dr. A once, Dr. B once, Dr. C 3 times, and Dr. B or Dr. D twice. So we would attribute that member to provider C because that provider had the most E&M services with that individual patient within the clinic over the last 12 months. So again, if there would be a tie within the clinic, if this patient saw 2 different practitioners over the last 12 months within that clinic, once for an E&M for each physician, then we would move on to, again, tiebreaker number 2, to where we're looking at the most non-E&M services between those 2 physicians. And then again, let's just say there were 2 non-E&M visits within that 12-month reporting period from each of those practitioners. So then we look at the most total visits. And again, if there's a tie there, we would look at the PCP within that clinic who had the most recent visit with that individual patient. And then we would end up attributing that patient to that physician. But again, that happens very, very rarely do we need to get off that level of detail. Typically, we can identify the provider group with the most E&M services in the past 12 months, and then just pick the clinician with the most E&M services within that clinic, and then that's the primary care physician that the patient would be attributed to. The vast majority of patients, that's the way it happens. So the next slide is just a kind of a visual representation of just what we just went through. So what we have here, 2 different medical clinics. We have ABC and then we have XYZ. And you can see, looking back the last 12 months, this member has had 13 different E&M services total at 2 different clinics, right? So the PCP within XYZ medical group has the most total E&M services. There have been 5 visits within the last 12 months. However, that member would not be attributed to XYZ medical group. They would be attributed to ABC medical group because there have been a total of 8 E&M visits within that clinic within that same reporting period, within that same 12 months. So remember, we attribute to the clinic first and practitioner second. So the first pass through would say, okay, we're going to attribute this member to ABC medical group because they have what we call the plurality of visits within the last 12 months. So we're going to say, okay, we're going to attribute this member to that practice. And then at that point in time, we'll start the second wave or the second level of attribution. So we're going to look at the individual physicians within that clinic. And as you can see, Dr. C has had 1 E&M service with this patient over the last 12 months. Dr. A has had 3, whereas Dr. B has had 4. So that member, that patient, would be attributed to Dr. B within that ABC medical group because that physician has had more E&M services with that individual member than anybody else within that clinic. So that's really all that I had for the power play. I think that's the last slide, right? Yeah. So that's the last slide that I have there. I'm sure that there's probably some questions out there from the SERPA care coordinator. So I'd be happy to answer any questions or to have any discussion that you'd want to have related to attribution or how it's done, or if there's anything in my presentation that was not clear, we can definitely review that as well. Is everybody still on mute?
Yeah. If you want to ask Brad a question, just click on your either your phone set or your microphone there. It's orange. If you just click on it, it'll turn green and you'll be able to talk.
Okay, so a question just came through on the chat from Laura, and it says, it's my understanding that someone must be a member for 7 months to count. So there are two types of attribution that we run for our programs. The first type of attribution that we can talk about, which is related to the 7 months, is budget attribution. And so what budget attribution means is within a reporting period or within a 12-month period, so like a program year, we would need members to have 7 months of eligibility and be attributed to an ACO for those members to count to that ACO's budget. So the 7 months doesn't necessarily need to be contiguous coverage or contiguous eligibility, so a member could drop off and then come on later. But what we've done is in budget creation, we've put those parameters in place so that we have a more stable data set when looking at budgets, so that we don't have new members coming in and members leaving frequently. We've found historically, and our vendor has as well, that if you use that methodology, there's way too much variability in the data. So that's just for budget attribution, to where we're looking at SERPA-ACO performance compared to a specific budget number, right? The other type of attribution that we're looking at is population attribution. And so if you're a care coordinator and you're looking at your clinic's data within the dashboard, typically you're looking at population attribution. And population attribution only requires 1 month of eligibility and attribution to a primary care provider. So it's much more easier for somebody to become attributed to a provider in general using that 1 month population attribution. And then even though we measure our ACO's performance based on that more restrictive 7 months inclusion within the program year, the budget attribution logic, when we pay you care coordination and shared savings, we're paying you based on population attribution. So we're paying you on that larger group rather than the more restrictive 7 months within the budget year.
For purposes, how are OB codes treated versus E&M codes?
I'm sorry, was somebody talking? It was hard to hear there.
Brad, do you want to mention, or is there anything that accounts for house calls for a few of us who still make an occasional house call?
Yeah, that's a good question. And I guess my question back would be, how are you billing those house calls?
Well, we usually just make a house call, and there is a billing code for home visits somewhere in CPT. I don't know what it is, but there is a billing code for it.
Is that code within the E&M range?
I believe so.
Okay, so I guess we would have to look at that, because if that code is within the E&M range, and the bill type that you're submitting it, are you submitting it as like an office visit, or what bill type are you submitting that as?
We don't do it often, so I'd have to look it up, but I can look it up when I can give you the code numbers and send it to you, just for those physicians who might. This is typically more often going to occur in the Medicare age range rather than the Blue Cross, but it would be good to make sure it's at least they know about it, since if you made a house call on somebody because they couldn't come in, and you'd seen there would still be a potential attribution issue.
Yeah. So if you want to send those in, that information, we can definitely take a look at it. But if you're billing a CPT code that's within that E&M range, and you're billing it, let's just say, an office or something like that, and the bill type, that would apply towards attribution. But if you give me the details, we can definitely take a look at that. It looks like another question has come through via the chat. Family Practice Carney had a question: how are OB visits treated for determining attribution? So again, if this is if it's an OB/GYN or a gynecologist providing the service, they are eligible for attribution. And if they are billing one of these CPT codes, one of these E&M CPT codes, in one of these types of locations, then that OB/GYN will receive attribution based on how the algorithm's set up. One thing that I should probably mention too, and I know it's listed down here, but it's kind of in the fine print. So with the mid-level practitioners that are listed here, all with the asterisk next to their specialty, they need to be practicing within a primary care clinic and under the supervision of a primary care physician in order to be eligible for attribution. So if there's a nurse practitioner that's working in some type of, let's say, an allergy clinic or something like that, that practitioner wouldn't be eligible for attribution, because again, they're not working in somebody who we've defined as being a primary care location. Let's see if there are any other questions that have come in here. Looks like Laura had a question. How about family practitioners doing OB visits? Again, it's the same logic would apply. So just go back here and see that family practice docs, that specialty is recognized as being eligible for attribution. So if they're submitting one of these CPT code range and they are providing the services at one of these types of locations, then that visit would be eligible for attribution. All right, another question came in, it looks like from Beth. The question is, so do patients go off your attribution monthly, or how long does it take to get patients off? So attribution changes monthly based on historical utilization. So if we go back to this last slide, so we can see here that, let's just say this was the March data refresh, and so this member would be attributed to Dr. B within this medical group for that February refresh. But then let's say the following month, for some reason, this member went and saw this Dr. D 5 more times within that month. So within the reporting period, this physician would have a total of 10 E&M services, which would obviously be more than the 8 provided here at ABC Medical Group. So the following month, this member would then be attributed to this physician within this XYZ Medical Group, and that member's information would no longer show up under the ABC Medical Group. So that's why you can go into the dashboard sometimes and you can see there's a patient that's attributed to your organization, and then you go in the next month and you can't find that member. Well, it's either based on historical utilization that member is no longer attributed to your organization, they're attributed somewhere else. Maybe they're not attributed anywhere. So maybe this is that member who has had no historical utilization in the last 12 months. So we do the 24 months look back. 23 months ago, she saw a physician in your office. We refresh into the next month, she's still attributed to you because she saw a physician in your clinic that met the criteria for attribution 24 months ago. But then the next month when we go to refresh, that visit is now 25 months ago. So that person's going to drop off your attribution. So that's why it's important to go into the dashboard and look at your, there's some outreach lists and the PDFs on the population pane, the right page of the right-hand side of the dashboard, which will show you member lists of individuals who are going to fall off of your attribution because they haven't been in. And of course, people can fall off attribution due to terming coverage as well. So that's another reason why you see your attribution change every month. As we sign new groups and new members come on, they'll start utilizing services and then become attributed, as well as, you know, if we lose groups or we lose members, those members will fall off attribution then.
Brad, this is Jolene.
Yeah.
And I just need a clarification. So, and I'm sorry to beat this horse, but for population health, we will get the care coordination payment based on the population health, which it does not have that 7-month look back.
Correct.
But when we look at our budget money and the shared savings portion, that will have the 7-month attribution look back. Is that correct?
So when it's partially correct. Let me maybe try and clarify it a little bit. So when we're looking at performance, we're only including those members with 7-member months or who are projected to have 7-member months of coverage within the reporting period or within the program year, right? So
and when you say performance, are you talking the care coordination payment, or what are you talking when you say performance?
So no, I'm just talking about within the performance year. So within the program year, within that, so for the current performance year would be 7/1/17 to 6/30/18, right?
Okay.
And so when we're looking at budget criteria, we're looking at seven member months within that 12-month period, right? And so when we're looking at your performance to budget in terms of a PMPM, we're only including those members that have 7-member months. However, let's say that you guys do very well in your program year and you're in line to earn shared savings. You finished below budget, so we're going to share savings with you. When we go to pay you shared savings, we're going to pay you based on population attribution and not budget attribution. So we're going to pay you for those extra members. Did that clear it up, Jolene?
It's to our benefit, so I think so.
It is to your benefit, yeah.
I think it's to our benefit, so I think it's clear as mud. I like it.
Yeah. So we realize that you're caring for these people, that they may not meet budget inclusion criteria, but you're caring for them, right? They're attributed to your organization. So we thought that was the right thing to do. that would be to pay you for those if you do earn shared savings.
Thank you.
Sure. Okay, a couple more questions have come in. So it looks like Andrea wants to know, when will we receive the list of patients attributed to our clinics? I'm not sure what that question is referring to. So you do have a list of attributed patients within your dashboard that's refreshed every month that will show your attribution. So maybe, Andrea, if you have a different question, or maybe if there's something more specific that you're looking for. But yeah, your population and budget attribution updates every month when the data is refreshed, which is typically around the 22nd of the month. Sometimes it's a little earlier, sometimes it's a little later. But yeah, all of those members will be represented within your dashboard within the 3M tool.
And Brad, this is where
yeah.
Here at the ACO, we are generally sending out those attribution reports as well on a, Jolene, correct me if I'm wrong, but on a monthly basis or quarterly?
It's monthly, but they have, like Brad said, they have access through Treo for those reports themselves.
Yeah, everybody should be going on Treo and looking. You can look at all your own data, and the attribution is real time. You should know who your patients are.
Yeah, and if there are any clinics that need any refreshers on the dashboard or anything, just let us know and we can set something up as well. Looks like another question has come through from Columbus Family Practice. It says, on Treo, does the all member list include who the members are attributed to within our clinics? Yeah, so if you pull open that all member list, which again, that's in that population pane, which is on the right side of the dashboard. If you pull up that all member list, there's all types of great information related to all of your attributed members. So you can see the PCP that they're attributed to. You can see what their CRG is, what their spend has been, if it's above expected in certain areas, inpatient, outpatient, if there's been some potentially preventable events. So that all members report is a great tool to start with in terms of looking at your attributed population and helping to manage them, and also understanding maybe who needs to come into the office for a visit. So again, if any clinics want to have a greater discussion to kind of get into the weeds on that as well, we can definitely do that. Just let us know. So
any other questions?
Yeah, there's no other questions coming in through the chat function.
Sounds like you've answered everything, Brad. Either that or we don't know what to ask.
Well, if anything comes up in the future, just shoot me an email. I'm always around, so we can respond to your questions that way as well.
Janet, do you have anything else?
No, and Brad, I appreciate you taking the time to go over this with everyone. So I don't have any questions.
Do you want to just mention the session next week?
Yeah, first of all, we recorded this webinar, and I believe it takes a week or two to get this uploaded and put on Basecamp. So you can look in maybe a couple weeks to find it. And then next week or that's not next week. Yeah, it is next week. On the 24th, Brad will be doing another conference on chronic care management, the Blue Cross Blue Shield program. And that's from, I don't have it right for me, 12:30. What's the time on that, somebody? At 12 to 1, I believe. Anyway, I have it posted on Basecamp in your schedule that you can look for, and LeGrere has sent out an email with the invite on that also.
It's 11:30 to 12:30.
Okay, thank you.
Hey, Janet, we just have one more question pop through.
Okay.
Sherry is asking, does it count if Blue Cross Blue Shield is secondary? So good question. What we call that is COB, or coordination of benefits, and individuals that have coordination of benefits are not eligible to be attributed to any of our value-based programs, just because we don't have the ability then to understand kind of the total cost of care for those members. So they're not eligible for attribution. Okay, well, I think that does it for the questions in the queue. So thanks for inviting me today, and I will I guess talk to everybody next week.
Okay, thank you very much.
Okay, goodbye.
Bye.